Okay, so I'm just gonna do an introduction again just for the camera. My name is Jerome Alonso. I'm a sleep physician. I'm actually the medical director for the Canadian Sleep Consultants, which is a clinic across the Foothills Hospital. My residency training was in family medicine, but I did a fellowship in sleep medicine, which is it's a little bit of a young field here in Canada. There's very few fellowship programs in Canada, but in the States, you know, Stanford's been around for about 30 years. So it's a little bit of an older specialty in the States. But I'll talk to you specifically about sleep and chronic fatigue and fibromyalgia and how we'll try to get down to the biology of sleep to a certain degree so that we can understand how certain things help when it comes to chronic fatigue and fibromyalgia. So I'll talk about sleep and sleep-related symptoms with the data that we have, and then I'll also talk about commonly associated sleep disorders. Now, again, there's not a lot of data, and they're conflicting, and it's part of it that plagues research in general is funding. And so there's a lot of studies that will use substandard measures for sleep, or not substandard, but inferior measures. And so, you know, we'll have to take that into account. And then we'll talk about sleep studies and when they're necessary. And then we'll talk about the different types of sleep studies, because you'll hear a lot. And here in Canada, there's a lot of take-home sleep studies, and I'll talk to you about the limitations with that as well. And then we'll talk about sleep-related signs and symptoms. Sleep-related signs and symptoms. And I'll actually talk about things you can do to help with insomnia, which is very common in both chronic fatigue and fibromyalgia. And I'll also talk briefly about medications. I don't want to get too deep into that because I might start, you know, as a sleep doctor, even when I see patients who have fibromyalgia, of course, I'm within the confines and bounds of treating the sleep aspect, because once I start extending out, then I'm going beyond my bounds and beyond my expertise. So I usually focus on the sleep side, so I'll talk about that. So when it comes to sleep-related symptoms with chronic fatigue and fibromyalgia, we know there's a lot, and it's very common. And the thing is, there's a very large overlap between fibromyalgia and sleep disorders and things that we know about sleep disruption, fragmentation, and how they can affect daytime functioning in people without fibromyalgia and chronic fatigue syndrome. And so the nighttime symptoms, it's very common to have problems falling asleep, staying asleep, early morning awakenings, and of course, that will have subsequent daytime symptoms like having non-restorative sleep. Excessive daytime sleepiness is a questionable thing, and I'll talk to you about that, because there's in the sleep field, we always talk about the difference between subjective and objective sleepiness, because we can feel sleepy, but actually we won't truly have objective daytime sleepiness. A prime example is depression. In depression, there's almost all patients with depression will say that they have this big sleep need and they'll spend lots of time in bed, but actually only about 16% will have true excessive objective daytime sleepiness. And then one thing that I'll talk about briefly is actually sympathetic instability, because we see this in certain sleep disorders, and we see this in fibromyalgia chronic fatigue syndrome, and there's a lot of talk about how there's an overlap between the two and whether or not that connection needs to be looked at to a deeper level. And unfortunately, even there is some, you know, so that's been known for a while. Unfortunately, there's not a lot of people who sleep fibromyalgia study sleep and fibromyalgia and chronic fatigue syndrome, and even the ones that do, interestingly enough, they'll do incomplete sleep studies, and I don't really know why they do that. And when you have a full hookup, you'd think you'd get all the data, but then they'll do a study and only look at sleep architecture, and it puzzles me. But unfortunately, that's what some of the guys doing the research in fibromyalgia, chronic fatigue, and sleep are doing right now. And then GI discomfort is very common in sleep, and from what I understand, it's very common also with chronic fatigue and fibromyalgia. So the question is, why should we be interested in sleep with chronic fatigue syndrome and fibromyalgia? One is, of course, when we have poor sleep, we know we can be tired, we can be sleepy. But there's a study that's actually very old. It's about 30, 40 years ago from Dr. Moldovsky that showed that if you fragment someone's sleep and you eliminate slow wave sleep and REM sleep, you can actually create a fibromyalgia picture. Patients will wake up with multiple pain points, they'll be tired. And even some of the studies that looked at subjects who did not have fibromyalgia or chronic fatigue syndrome, if you let them sleep 10 hours, but fragment their sleep with an earpiece in their ear, and you make it quiet enough so that they don't actually wake up, they'll wake up tired with pain points. And so that's the thing, is if you can create a fibromyalgia similar condition with just fragmentation, then we always want to find out if there's any patients out there that are actually a secondary type of fibromyalgia, or at the same time, or whether or not we're aggravating a fibromyalgia or chronic fatigue syndrome. From experience of seeing chronic fatigue or fibromyalgia patients, to be honest, we usually, from a sleep side, we allow for improvement. We usually don't actually have elimination of the condition, but we do allow for some improvement. I'll talk to you about that. And then when it comes to sleep deprivation, so I'm going to be talking later on a little bit about adjusting sleep patterns, and then that's where the whole, that's where we're going to touch on this again, because we know that sleep deprivation can lower the pain threshold in fibromyalgia. So they've done studies on a 40-hour sleep deprivation. Well, it's not really a 40-hour deprivation. It's a 40-hour protocol of being awake in fibromyalgia, and it actually increases, it lowers the pain threshold. But with cognitive behavioral therapy used in fibromyalgia, we actually don't sleep deprive. We tailor time in bed and curtail time in bed. And I'll sort of explain that, because there's actually good evidence on the use of that in fibromyalgia at least. There's not a lot of data in chronic fatigue syndrome. And like what I mentioned, REM sleep and slow wave sleep deprivations can actually lower the pain threshold. And then we know that fibromyalgia is associated with a lot of impairments. So there's so these are technical terms, I'm sorry. So fibromyalgia patients commonly take more time to fall asleep. They have longer periods during their sleep period where they're awake. There's less slow wave sleep, less REM sleep. There's more movement, twitching at night. And there's something called alpha intrusion in slow wave sleep that some of you have probably seen on the internet, where they talk about there's multiple bursts of alpha. So basically, if any of us are asleep and someone rings a bell, you can get alpha intrusions. And so there's some idea that there's chronic fragmentation that's intrinsic to fibromyalgia. And then there's something called CAPS, which is really interesting. It just looks at the stability of sleep, and there's evidence that the overall stability of sleep in fibromyalgia is not very good. And then there's a lot of sympathetic nervous system activity in fibromyalgia, which we also see in a lot of sleep disorders. And so that's part of the reason why some people are talking about whether or not there's a connection between the two that we should be investigating deeper. And then 80% of chronic fatigue patients will perceive poor sleep quality. They'll have light superficial sleep. They'll have problems falling asleep because of their mind going. And then they'll also have external and internal sensitivity. So there's these discomforts that are internal and also sensitivity to external stimuli, which I guess is sort of, I guess, similar to be honest, I don't, my knowledge is really sleep, so I don't want to overstep and start talking about chemical sensitivities or anything like that, but I understand that's a little bit of what the external sensitivities are. And then there's also an overlap between, like I mentioned, there's an overlap between symptoms of sleep disorders and chronic fatigue and fibromyalgia. And so one of the questions what I get is there a difference in sleep need if you have fibromyalgia versus not having fibromyalgia? And so this is one thing I think we should definitely look at. And so this is a study that was done by Thomas Roth, who's in Henry Ford. He's actually a very pronounced sleep doctor. And he was actually looking at objectively the quality of sleep in fibromyalgia versus rheumatoid arthritis versus normals or healthy controls. And this slide, basically, I'm not going to go through the numbers and details, but basically there wasn't a large difference. So with this slide, sleepiness is a little bit higher in fibromyalgia, but in fact, this sleepiness is still within normal. And overall, there wasn't a lot of difference when it comes to the two groups, when it comes to some subjective measures. When we start getting to objective measures, this is where I think it helps us define excessive daytime sleepiness from a subjective versus a objective standpoint. So you'll look here, the total sleep time of the fibromyalgic patients was only 6 minutes and 6.72 hours, which is actually, it's less than healthy controls. But when we're actually measuring sleep need or how much sleep someone requires, we actually look at daytime sleepiness. And daytime sleepiness in fibromyalgia, objectively measured, so this is having someone hooked up with a sleep study and taking naps to see how quickly they fall asleep, is actually lower. So overall, if you pair this data together, fibromyalgics actually have decreased sleep need. Or basically, 6.72 hours of sleep does not correlate with objective excessive daytime sleepiness, suggesting that the actual amount of sleep is no greater than normals. But I'll talk to you about that, because sometimes when it comes to fatigue states in general, so not just in fibromyalgia chronic fatigue syndrome, because we also see MS patients and other patients that have fatigue states, sometimes we have to tease out the difference between resting and sleep, because sometimes people will try to seek out amount of sleep, when in fact what has better evidence is quality of sleep. So shorter sleep of better quality is actually better from a restorative standpoint, and basic biology tells us that, and I'll try to go through that to a certain degree, versus having a long period of sleep with very little sleep. And so sleep need is very important for us in the sleep field, because basically if someone asks me, well, do I need more sleep? I said, well, we have to define what your sleep need is, and we look at that clinically. There's ways to measure that clinically. And so we target a time in bed equivalent to someone's ability to sleep, but we have to define ability to sleep, because if you try to get more than what you're able to do, you'll just create insomnia and fragmentation. And the problem with that is if your sleep's fragmented, you actually cannot cycle to a deeper stage of sleep, because you just went stage 1, stage 2 awake. Okay? So there is objective evidence that the actual total amount of sleep need in fibromyalgia is not any greater than normal controls. And then sorry, I think my slides are, so I'll just go back to the other slide. And the other question is about in chronic fatigue syndrome, if the actual amount of sleep need is actually elevated. And so this data is not as robust because this is actigraphy data, or this is data on movement. And unfortunately, movement measures are not as good as sleep studies, and we know that with studies comparing the two. Because basically, if you lie in bed and you just keep yourself from moving, it'll think you're asleep, because it's basically just a movement measure. But even when it comes to movement measures, it looks like chronic fatigue. There's the actual duration of sleep there's not a big discrepancy. So if there is a discrepancy, it's about maybe 0.7 of an hour. And again, if there's lack of motion, that'll be interpreted as sleep. So it's really hard to define whether or not chronic fatigue syndrome is actually associated with increased sleep need. So there's not a lot of good evidence that there is. Now there's a lot of sleep disorder. The other question is are there sleep disorders that are also associated with chronic fatigue syndrome, fibromyalgia? And so there's some talk about restless leg syndrome and periodic limb movements and sleep being associated with fibromyalgia, and there's actually a study that demonstrated up to 33% of patients with fibromyalgia will have restless leg syndrome. Now, in the general population, there's a variability in that. There's about somewhere between 5 and 15%. Unfortunately, that's also plagued with definition problems. But when it comes to restless leg syndrome, there may be a higher percentage of patients with fibromyalgia who will have restless leg syndrome. But to be honest, in the sleep field, there's a lot of evidence that restless legs affects ability to sleep, but does not really affect quality to a large degree. And then obstructive sleep apnea, despite all the studies looking at, and the other one is upper airway resistance syndrome, which is sort of a sub-disorder of sleep apnea, not quite sleep apnea, but can also cause fragmentation of sleep. There's not a lot of good data. So there's one study that said, oh, it's a very low association, but basically what they did was they did a questionnaire screen, and then said who's high risk, who's low risk, and they did sleep studies on them. And then so they said that there's a very low association with obstructive sleep apnea in women, but they actually did sleep studies on 4 women, and 2 women had sleep apnea. And so, if you studied everybody, then that would be a different picture. When it came to the men, they did sleep studies on 15 out of, I think, 45, and 11 had sleep apnea. But that's the thing, is it might be their screening tool. I mean, if their screening tool is sort of pointing out everybody with sleep apnea, then, but the other thing is whether or not it's excluding people that might have sleep apnea. And then psychophysiologic insomnia, I've noticed in my practice, is very common with not just chronic fatigue syndrome, fibromyalgia, but in fatigue states in general. And psychophysiologic insomnia is the old classical insomnia. So that's where you can't sleep, you worry about the fact you can't sleep, even more so you can't sleep to the point that you actually teach yourself that you can. And what I mean by you can teach yourself that you can't sleep, this is when you feel sleepy, you're ready to go to bed, you get into bed and you're just wide awake. If that ever happens to you, the thing I always tell my patients, I'm pretty sure your bed sheets aren't lined with something making you awake. It's a psychological association. And so we have to make sure that even, unfortunately, those can actually prevent you from getting more sleep, because insomnia is actually a defense mechanism. If there's something that's a threat to you right now, your brain's response is, hey, you gotta be awake, you gotta be awake to address that. Now, if your threat is the threat that you won't be able to sleep, you've just created a self-perpetuating cycle. And so that's very common with fatigue states in general. And then delayed sleep phase syndrome is sort of the opposite of what we talked about with light exposure. So we actually like light exposure from the sleep field in the morning. We don't like it at night. And so there's some studies that have actually demonstrated that, yeah, so in children, they've shown that if children gain 30 minutes or 1 hour before bedtime, will affect their ability to fall asleep. But if it's 2 hours, if there's a 2 hour buffer, it won't affect them. And that's thought to be about light. But one thing that's very important in sleep is actually fixing your wake up time so that your body clock synchronizes. Because if your wake up time varies, your body clock moves. And it can create something called desynchronized sleep, where you're sleeping and your body clock's not secreting melatonin. And that gives you a poor quality sleep. But what I can frequently see with fatigue states is because of the tendency to sleep in, the body clock will move, and then there's going to be periods of insomnia because the body clock's not secreting melatonin. And then one is something called inadequate sleep hygiene. I know it sounds like a really bad term. They need to find a better term for it. But basically, it's when sleep is all over the place. And it's usually when people start chasing amounts. That's usually the cause of inadequate sleep hygiene. I didn't get enough last night, so I need to take a nap today. Or, oh, I need another nap. There is value in napping in certain situations. And basically, the value of napping is when your opportunity to sleep is too short for your ability to sleep. So you'll hear this, well, of course we hear it because we're sleep doctors. You'll hear about Olympians taking naps right now, especially with everything that's going on. Certain athletes actually have long sleep needs, and they actually can't sleep that long because opportunity is not there. Like they have to wake up for their morning trials. And so for them, a nap is good because it's actually addressing a deprivation. But a nap that is not addressing a deprivation is just stealing your nighttime sleep. And at the end of the day, nighttime sleep is better than daytime sleep. Okay. So I went over this. And so the other thing is when do we start looking at whether or not your sleep needs to be investigated from a diagnostic standpoint? When do we start looking for other sleep disorders? And usually what you'll see is there's no real guidelines on that. And basically what they'll say is if there's symptoms of a sleep disorder, then you should do a sleep study. Now, a symptom of a sleep disorder is non-restorative sleep. And I wonder how many of our fatigue patients feel that they have non-restorative sleep. And I mean, that's the main problem, right? So in an ideal world, it would be nice if we had a sleep study on everybody who has non-restorative sleep, because we want to make sure, the way I always address my patients who have fatigue states is that if you have a fatigue state and your reserve for energy is low in the first place, I don't want one of my disorders contaminating your daytime functioning. So if there's any indication that there's a problem with sleep, then of course I'll suggest sleep testing. But in an ideal world, all of my fatigue patients have non-restorative sleep. So all of them should actually be getting a sleep study. But I know that it's difficult in Alberta because of the fact that sleep studies are not funded by Alberta Health and Wellness. And so the only real avenue for sleep testing that's funded by the government is through the Foothills Hospital, or going through one of the home respiratory care companies. But that's a whole different thing, the home respiratory care companies, because I don't want to get into that. And then there's always, and the other thing is the nice thing about sleep studies, which we love when we see full in-lab sleep studies, which we don't get to see a lot, is we can actually have patients with fragmentation of sleep who have a sleep disorder, treat them in the middle of the night, and we actually see the quality improve. We see that the arousals disappear and the stages of sleep start to cycle. And when you have someone with a sleep disorder and you treat them, the brain's very good at grabbing what it can. So if you have a sleep disorder that's fragmenting the quality of your sleep, you're not going to get a lot of deep sleep, not a lot of REM sleep, and if you remove that, the first thing your brain's going to do is binge on them. And then we see that in lab sleep studies. We see the increased deep sleep. We call them rebounds. Deep sleep rebound, REM sleep rebound. And the body will just start binging on all the good stuff that it lost for a while. Yeah. And then when it comes to sleep testing, there's a couple types of sleep tests. There's these take-home sleep tests that I'm sure some of you have already had. So these are sleep apnea tests. So just remember, when they say in-home take-home sleep test, these are purely sleep apnea screens. And we have to remember that these are low sensitivity tests. So if they say you don't have something, it doesn't mean you don't have it. The other problem is a lot of patients with chronic fatigue and fibromyalgia will have an insomnia component. You'll notice that these tests don't have brain electrodes. So if you're awake in the middle of the night while that's recording, pretty sure you're not going to snore and have sleep apnea awake, but that machine's still going to record it. And so that's going to be the challenge there. So if you're suspicious, if you snore, you have a lot of fatigue, you've had these take-home sleep tests, remember they are not rule-outs. Okay, they're rule-ins. If they say you got it, you probably got it. If they say you don't, doesn't mean you don't have it. And then there's the in-lab sleep test. Unfortunately, in the private setting, it's about $800 to do an in-lab sleep test. If you go through the Foothills Hospital, to be honest, they don't offer it to a lot of patients because they have about 80 beds per month. But this is actually the better way to look at sleep overall. But if even from a sleep apnea standpoint, this will also allow us to find the patients that negative out on these take-home tests. And one thing that's important to remember is, well, the thing I think is very important is if you have mild sleep apnea, it doesn't mean that you can't have sleep symptoms. Okay, so one of my mentors, he developed the in-lab clinical sleep test. He talked to us about how their monkey ran up a tree and they almost lost all their data and couldn't create the sleep test. But what he used to tell us in the beginning was, when they decided the severity scale, they actually were in a circle in Chicago and just said, hey, what should we make mild? Why don't we make 5 to 15? But the actual evidence is that if you have more than 5 breathing events an hour, you can have affectation of daytime functioning. So mild patients can have symptoms, and actually a recent study demonstrated that 25% of mild sleep apneics will have excessive daytime sleepiness. So when it comes to non-restorative sleep, it's probably even higher than that. Okay. And then when it comes to avenues for sleep testing, I sort of talked to you about that. So there's the hospital-based testing through the Foothills. Unfortunately, it's a 12 to 18 year wait list, and they'll usually do a take-home study first. There's a couple sleep medicine clinics. So there's our clinic. There's also Center for Sleep and Human Performance down in the south. And then there's Med Sleep down in the south. And then there's a whole bunch of home respiratory care companies. Just remember, because a lot of times people will go through the home respiratory care companies, and sometimes you'll feel that CPAP is the only way to treat sleep apnea. There are other ways to treat sleep apnea. Okay, it's just that sometimes some of these roads will only end to CPAP. There's no other avenue because it's just a pathway that you go through. I can at least tell you confidently that through the hospitals and through the clinics, we will tell you about all treatment options available. And so you don't get stuck. Some of the dental offices are doing sleep studies. I can't really comment about that because there's a lot of variability. I've seen sleep studies without interpretations, and so I don't know too well about whether or not they're regulated or not, and how good the quality is. But that's the other way for sleep testing. And then when it comes to major considerations that I always look at, so one, if there's any sleep disorders, remember sleep disorders can make you tired. So I will always target and treat those. And then there's something called cognitive behavioral therapy for insomnia, which I'm going to talk to you about, which can help a lot for the insomnia, and has actually been shown to improve pain and fatigue and fibromyalgia. And I'll talk to you actually about a specific study looking at that. And then the other thing is that there's when it comes to medications for sleep, sleep medications allow for some subjective improvement, but actually for improvement of pain, they haven't really shown a lot of advantage. Now, there are certain medications for fibromyalgia that can affect sleep that aren't specifically sleep medications. So, there's some cyclobenzaprine and amitriptyline, which aren't, completely sleep drugs, and actually sodium oxybate has some evidence too. But when it comes to sleeping medications themselves, so for example, the Z drugs, the zopiclones, the benzodiazepines, they can allow for some subjective improvement in sleep, not a lot of objective improvement, and there's not a lot of good evidence that they improve pain. But remember, I'm talking about sleep medications. Okay, so like I mentioned, there's some medication like duloxetine that can help the pain aspect, but not necessarily the sleep aspect. And then I'm going to talk to you about cognitive behavioral therapy because I think this is very important. So the study that really looked at cognitive behavioral therapy for insomnia, so this won't be in your slide because it's a little bit more technical, but basically what this slide is telling you, if you wanted to take something home, is that don't go chasing after amount of sleep, chase after quality, because quality is what's going to make you feel better. So what they did, and there's actually they actually did a follow-up study, probably it's not published yet, but they've talked about it at the sleep meetings. But basically what they found here was they took patients with fibromyalgia, and then they divided them into 3 groups. So there are a group of them that had cognitive behavioral therapy for insomnia. There's a group that had just sleep hygiene, and then there's a group that just had regular fibromyalgia care. They just said regular, so there's no real definition of what they mean by that. But what they did was they took these 3 groups and they followed them out. And what they found was the patients with sleep hygiene and cognitive behavioral therapy actually had improvement in reduction in their time awake, both before falling asleep and in the middle of the night. They had improvements in their energy levels, and they actually, this study didn't show the improvement in pain, but they actually presented the data from the follow-up study, where they actually found objective improvement in tender points in fibromyalgia in the subgroup that actually had improvement in the insomnia. So unfortunately, it was a subgroup. But cognitive behavioral therapy, I'll talk to you a little bit about this. So when it comes to sleep, I just want to make sure I start one time. So when it comes to sleep, there's actually two main biologic mechanisms by which we sleep. Okay, so one is the longer you're awake, the sleepier you get. So basically up here on top is the drive to sleep. So the longer you're awake, you build more drive to sleep. And that's why we usually get tired in the second half of the night until this second drive system that makes us more awake sort of perks us up. So if you translate it to your regular day, most of us, except for our night owls, probably start to feel tired or sleepy about 1, 2 p.m. And then we get that second wind that comes about 4 or 5 p.m. And then you start feeling better. And that's because you get this alerting signal. And then eventually you should build sleep drive, and then eventually you actually fall asleep and stay asleep, or that's what we want, right? The thing about the sleep drive mechanisms, though, is this mechanism that builds our need to sleep is actually the same mechanism that gives you deep stage sleep. So they've done studies in animals where if you take, I know it's really brutal, but you take a needle and take something called adenosine, which is what we build up when we're awake for a long time, and you squirt it into their basal forebrain, they'll get more deep sleep. Of course, we're never going to do that on humans. But then we know that adenosine is sort of what helps us get deep sleep. So one thing you always have to remember, to get deep sleep, you have to be awake long enough. If you're awake for a shorter period of time, you actually have less deep stage sleep, and you'll actually have lower quality sleep. So in the sleep field, we call this a sleep trap. Because if you stay in bed longer to get more, so one, I always tell patients, think of your time in bed as a container that holds your sleep. If the container is too big, it's all going to fall apart. And so you're going to get fragmentation of sleep. Because basically, if you're in bed for 10 hours and you can only sleep 8, the 2 hours have to go somewhere. So it's either a problem falling asleep, or it sneaks in the middle and fragments your sleep, gives you all this light sleep, or you wake up in the morning and you can't fall back to sleep. But the other thing is actually, the time awake is what gives you deep sleep. And we have all this data even from pain patients. So they've done these studies looking at pain control. And actually, if someone stays in bed for 10 hours but gets 6 hours sleep versus being in bed for only 6 hours, sleeping 6 hours, they'll actually feel more pain being in bed for 10 hours, sleeping 6. And the main reason for that is there's some evidence that consolidation of sleep, or getting your sleep to be a single chunk, even if it's a shorter period, helps something called the descending noxious inhibitory signal. Am I saying it right? Or system. So basically, if you consolidate your sleep, you'll block pain. Because from a sleep standpoint, we always think of it this way. If there's something that's constantly trying to fragment your sleep, eventually what the brain says is, you know what, I can't bother the boss anymore. So they'll block it. And so in the sleep field, we call those K complexes. So say you're asleep and someone drops something, the first thing your brain will fire is a K complex. And what's that doing is they call it thalamic gating. The thalamus is saying, you know what, I don't want to wake up the boss. But sometimes it's a little bit too loud, so it wakes up the brain. From a pain standpoint, I think it's actually the descending noxious inhibitory signal. So it's doing the other thing, it's blocking the pain. So when it comes to stimulus control, so when they talked about cognitive behavioral therapy versus sleep hygiene, with sleep hygiene all they really said was don't have caffeine before you go to bed, and don't exercise before you sleep. And with cognitive behavioral therapy, it's different. So cognitive behavioral therapy, there's two components that are most effective. And one is you don't force sleep. Oh, sorry, thank you. So when I say don't force sleep, remember I was talking about how if you have insomnia, you get into bed and suddenly you're wide awake, that's a psychological association. So with stimulus control, we want to reverse that. So what we're doing with stimulus control is usually what we'll tell patients is don't go to bed unless you're sleepy. Because unfortunately, if you're tired but not sleepy, you're not going to fall asleep, right? And the thing I always tell patients is because when I talk about this, I actually have to sell it because it's hard. If you do a cognitive behavioral program, it's hard. And from my experience with fibromyalgia, it's a little bit harder for you guys. So usually with someone who doesn't have fibromyalgia, their hard period is about 3, 4, 5 days. For my fibromyalgics, it's usually 7 days, 8 days. Now, the good thing though is we have evidence to support that cognitive behavioral therapy is beneficial. Now, of course, whenever they do research studies, they stack it on their favor. And what I mean by that is they have someone following up every week to make sure that people are following protocols so that they can get the data. So in a clinical standpoint where you don't have that person to sort of cheer you on every week, you have to sort of do that for yourself and make sure that you stick to it and struggle through that first week, because it's really tough for the first week.
I reading that you go to bed after 20 minutes of perceived time.
Yeah.
Sleep.
Yeah.
So I do that because I'm tired of laying there trying to
Mhm.
figure out why can't I sleep.
Yeah.
What do you do? Like,
Yeah. So I've.
just repeat the question.
Okay, yeah. So the question was, what do you do with the 20 minutes of what do you do with the time where you're waiting for sleepiness, I guess basically is the question.
Once you get out of bed,
Yeah,
what
yeah.
do you do so that you can sort of calm yourself, or get yourself tired again so you can go to bed?
Yeah, so typically what I suggest is a dim light, non-stimulating activity. The reason why I don't, yeah, I know, I get that question all the time. Unfortunately, I've been drawn into that trap before. So I'll tell people, sometimes I tell someone, oh, read a book. And then they just love this book and they're all stimulated, they don't fall asleep. So usually what I tell patients, think of that boring thing that will make you pass out. So what some people will do is they'll read Reader Digest stories, short stories. Yeah, it's not long enough to draw you in, but it's enough that you're doing something. But again, dim light because of melatonin secretion. You don't want to, you want to be able to secrete melatonin. If there's light, then you're going to shut that off. So try to keep it as a dim light activity. Now the whole thing about stimulus control is that if you think of insomnia as a learned condition, the thing I always tell patients is anything learned you can practice and get better at, right? And so if you're in bed trying to sleep and you can't sleep, you're actually practicing your insomnia. And just remember, you don't want to get better at that, right? So when it comes to stimulus control, the whole idea here is to wait for sleepiness. So you're going to have to struggle through the fatigue. And it's harder for you guys. So just remember, even though you're tired, if you don't get that head bob, if you don't get the unintentional eye closure, what you're trying to do is you're trying to teach your brain that when you get into bed, you're going to be sleeping and you're going to fall asleep. And it makes sense. Some of you who are patients, you've heard my lines already. But basically, it makes sense that you can't learn to sleep until you learn to feel sleepy. And that's what stimulus control is doing. Yeah. The good thing about this, so I get that all the time too. The good thing about this is it doesn't take that long. So just remember, you're not going to erase years of insomnia with a single day. So if you follow stimulus control, you may not sleep that first night, you may not sleep that second night, maybe even a third night, but I tell you, it doesn't take that long. By about 4 or 5 days, you're going to be doing the head bob before it's your bedtime. And when that occurs, I always tell my insomniacs, if you're an insomniac and you're fighting sleep, you're waiting for a bedtime, because the other part is actually having a schedule, then that's the best thing in the world. Because remember, insomniacs try to sleep, right? What time do you go to bed? I try to go to bed at 10. But talk to anybody who sleeps well. They'll say, I go to bed at 10. I fall asleep at 10. It's a passive process. And for that to be a passive process, you have to be sleepy enough to fall asleep, right? Again, can't force sleep. The more you force, the more you try, the less likely you will, the more frustrated you get, and you actually practice your insomnia.
Well, what's the worst thing that you do if you're up after 20 minutes?
Oh, what's the worst thing?
Yeah.
Oh, so, okay. So what's the worst thing you can do when you're up and awake? Anything stimulating with a bright light. So don't, because TV, you have the light exposure. And the other thing is, don't start doing work that's going to stress you out, because then your stress hormones are going to start cranking. So alcohol's tricky. The problem with alcohol is that alcohol in itself is fragmenting. So there's actually studies in alcoholics that have shown that, of course I'm not saying you're an alcoholic, but there's studies in alcoholics that have demonstrated that the effect of alcohol and fragmentation of sleep can last up to a month after improving their alcoholism. And the other problem with alcohol is you have to convert alcohol to what it is, which is actually a drug, and it's about a 4-hour drug. So you pop up in the middle of the night and you still have fragmentation. And at the end of the day, in the sleep field, we try to avoid medication as much as possible because we want you to have natural sleep. Yeah, and so even when it comes to alcohol, I always tell my patients, if you're taking alcohol for your cardiovascular health, then great. I don't want to steal that from you, but it's not necessary from a sleep standpoint.
No, I'm just wondering if halogen lights or blue lights.
Yeah. So So I can't answer that completely because, to be honest, I don't know. But basically, the greatest effect is still with a 10,000 lux blue-green frequency light, but there's some evidence that low-level light can also affect melatonin secretion to a certain degree. And so anything that has a blue light, yeah. Can you answer that?
Well, I don't know if I have the answer to that.
They do? Yeah.
You know, but I had a question here.
Mm-hmm.
Now, I'm probably going to see out why this is throughout my entire life.
Okay. So yes, there's blue light with there's blue frequency light with halogen lights. Yeah.
So the question that I have to present to you is that there's always been a question to me that I never sleep more than 4 hours ever.
Mm-hmm.
So I go to bed and here's my routine. I mean, I start at 12 midnight and I exercise from 12 to 1 and just watch daylight. Okay? And I'm working on all my projects, so I guess I have coffee there. I'm up at 6 o'clock in the morning, so I go to bed at 2 and I'm up at 6 every day, every single day. But what will happen is that I will have to sleep. For example, I'm on a plane that I'm going to sleep. I will be totally out for like 10 minutes. I'm totally revived and I can continue on. Now, I thought everybody did this until I realized.
Until she met me.
Yeah, and so, but I'm thinking, is there something that they think the farmers get or that keeps us there at the age of 5, don't take care of that cat, as well, bus ride to school? Is there something that trained you early in life?
Yeah. So you know that's a complicated question. Yeah. So the question is so if you always wake up at 4 in the morning, or as a child you always had to wake up at 4 in the morning, can you be trained to wake up at 4 in the morning? And that's very debatable in the sleep field, because some people believe in that and some people don't. Because when it comes to sleep, basically, being awake and having your melatonin secretion is what allows you to fall asleep, and then it actually, in the first half of the night, it's able to maintain sleep. And then the second half of the night, you've already slept for a while, so your sleep drive's going down, your melatonin secretion's already going down, and that's what I call the unholy hours of sleep, because if you wake up, good luck if you're going to fall back to sleep. And so in the sleep field, like the way that I was trained and the way I practice is so basically that's a maintenance insomnia. And what we do is basically, with a pure maintenance insomnia, it doesn't sound like psychophysiologic insomnia, right? It's not the whole worry, can't sleep, all that kind of stuff. Yeah.
So I guess I have to ask you, is it, you know, I mean, I've never slept more than that, I feel fine.
Yeah.
If I do try to make myself sleep, I'll waste of time.
Yeah.
So I have to monitor.
Yeah.
So I guess the question I have is there a certain amount of sleep? Because everybody's different, and why are we worried about it if you don't
Yeah.
get up?
Yeah. So when it comes to, I'll first answer the maintenance insomnia part. So when it comes to the maintenance insomnia, usually what we do is we look for a disorder that's waking you up, because that's commonly what's going on. There's something waking you up, because in the sleep field we talk about what wakes you up isn't what keeps you up, because once you're awake, then your mind can keep going. Now when it comes to how much sleep you need, there's a lot of correlates with 6 hours and 9-hour sleepers. So if you sleep less than 6 hours, there's increased risk for cardiovascular disease. There's some associations with increased cancer risk, and this partly because of melatonin and all that kind of stuff. And then there's also the same things that we see with people who need more than 9 hours sleep. And so basically that's sort of the sweet spot, 6 to 9. We want, well, there's harm that's shown less than 6 and more than 9. Anything in between. Now, when it comes to adult sleep need, it's actually pretty consistent. It's at somewhere about 8.1 to 8.14 hours for adults. And so there's not a lot of variability. In children, there's huge variability, but in adults, there's not that much. Yeah.
I went to see a sleep doctor in the hospital,
Mm-hmm.
and she found that I should change my body clock. I'm night owl. I tried that, but I went back to my body clock.
Yeah. So if you look at actually the criteria for the circadian rhythm disorders or the body clock disorders, they're only disorders if it affects your lifestyle. So when I was still in Silicon Valley, you might hear about Google and all those companies where they let their employees come in whatever time they want, and they got playgrounds and basketball courts on site. I had guys that would wake up at 11 o'clock, go to work at 2 p.m., and they'd be awake all night, but they'd feel fine. If it fits your lifestyle, it's not a disorder. And so we don't actually have to move your clock. Now the problem is when the clock starts affecting your lifestyle. So if you're a night owl but you have to work and get up at 7 in the morning, and so you're getting short sleep, or you can't sleep at night when you need to be able to get the right amount. So there's some disorders where we'll move your clock so you can get enough. But if your lifestyle actually allows you to follow your tendency, then you know it's probably easier for you. Yeah, yeah. So if your body clock is a night owl clock and you're allowed to do that, then your quality shouldn't really be impaired. Yeah. So I'm sort of mixing.
Probably
Yeah.
one or two more questions, and then
Okay.
Mary Jo.
When you're talking about the length of time that you're awake,
Yeah.
I'm wondering what exercise has to do with that. Like, I got
Yeah.
exercise so I can feel tired after that amount of time. It seems to be just talking about like the time awake.
Yeah. So when it comes to exercise, so the whole thing about exercise is that exercise, when it comes from a sleep standpoint, actually improves the depth of your sleep. Now there's some evidence in the sleep field that, so there's two things that are a possibility there. So one is there's something called a thermoregulatory response. So basically when your core body temperature goes up, you get more deep stage sleep. But the other is actually the idea that when you exercise, you build up more adenosine that gives you more deep stage sleep. And so the only thing is, so exercise is good for sleep. The only thing is don't bring it too close to your bedtime, because then you have all the stress hormones cranking because you need them for exercise. So I'm going to get to the second one, which is sleep consolidation, because it's very important for CBT. So with sleep consolidation, remember how I was talking about that fragments of sleep aren't as good as one chunk of sleep? So usually what we do here is we look at, you need to gauge your ability to sleep. So if you're in bed for 10 hours, but you can only sleep 7, basically with the sleep consolidation, what you do is make sure your time in bed is no more than 30 minutes more than your actual ability to sleep. So if you can only sleep 6 hours, you should only be in bed for 6.5. Okay, and the whole idea here is you're chunking your sleep. Now, remember, when we do this, we don't cut out sleep, we cut out wake, right? We cut out the time you're practicing your insomnia, and we're cutting out the time that's encouraging the fragmentation of sleep. But then what we actually do is that every 7 days, we add 15 to 30 minutes to your total time in bed, if you're able to do that. Because the way you'll find out if your time in bed is too long is when you consolidate your sleep and you stick to that schedule and you gradually add 15 to 30 minutes as your sleep allows you. If you start to reach that point where the time in bed is starting to cause you to fragment sleep, that means you're not actually able to sleep that much. And you just remember, okay, that means my sleep need is not beyond this. Pull it back. And there's already evidence that shows that this will improve your energy level, and there's evidence that needs to be published, which has already been presented, that shows that even pain will improve. Okay, so that's the sleep consolidation part. And then the other thing is just good sleep hygiene stuff. So sleep hygiene is always fix your wake up time, so don't let that move around, because if you move that around, you can sort of think of the body clock synchronizing with your sleep. If your body clock shifts over, then you'll have a couple hours where your sleep's not synchronized. Regular exercise is good. Light exposure can be used in the morning to synchronize your body clock if you want. So this is more for your night owls. If you're a night owl, you know you're a night owl. Don't sleep in on the weekends, and light when you first wake up is probably going to help you maintain your schedule. And then smoking is, and from what I understand, even fibromyalgia, it affects the fibromyalgia in itself. But smoking can also affect sleep to a certain degree. Caffeine 6 hours before bedtime can also affect it. And snacking is more because of acid reflux. So we know more and more now that acid reflux actually affects sleep. So you don't want to be eating too close to bedtime. And so why is CBT effective? It's because quality is more important than amount, and always remember that. And remember that nighttime sleep is more restorative than during the day. And so remember, try to get out of the nap trap. Because the problem with the nap trap is if you nap, right after the nap you feel better. So it makes you think, oh, these naps are great. But what it's actually doing is it's decreasing the amount of adenosine, which is going to make your nighttime sleep better. And so the problem with the nap is that the effect is the next day, so you don't know it. So, and the problem is that if once you remove the nap, you're actually going to feel more tired for that week, because you just changed the pattern. So when you get rid of a nap, you're now extending your wake time, but the nighttime sleep before was of poorer quality. So what actually happens is you feel more tired until the pattern settles out, which will take about a week, and then you'll actually feel better. And then just remember, get rid of insomnia-generating behaviors, which is like staying in bed for too long, doing activating activities in the middle of the night, using light. And then I'll talk briefly about medication. I don't want to really touch on this too much. Basically, the Z drugs like benzodiazepines, zopiclone and benzodiazepines like lorazepam or Ativan and those medications, they can improve your subjective sensation of sleep, but they don't actually improve the pain. And from a sleep standpoint, they're not really necessary, because most of the time cognitive behavioral therapy is effective in itself. When it comes to the benzodiazepines, they actually deteriorate sleep quality. So they reduce deep stage sleep, they reduce REM sleep, and we actually want you to have that. The Z drugs are sleep architecture conserving though. Sodium oxybate, did I put this on the next slide? Yeah, so I don't know why I put it on this side. And then when it comes to non-sleep medications, there are some non-sleep medications like amitriptyline. I mean, some people will debate that amitriptyline is a sleeping medication, but to be honest, it's a non-sleep medication with a sleep side effect. But there is evidence that cyclobenzaprine can improve total sleep time, pain and mood scores, reduce evening fatigue, and then even amitriptyline can do that. And sodium oxybate, I'll talk a little bit about this just because I have more experience with this drug than most people. Sodium oxybate is a very interesting medication. So this is a medication that's used for narcolepsy. And it's a really fascinating drug with narcolepsy. But basically what it is, it's a deep sleep inducing drug. So if you take sodium oxybate, what it will do is it'll increase your slow wave sleep, reduce the fragmentation in sleep, and it's actually been shown to reduce pain and improve quality of life even in fibromyalgia. So sodium oxybate is actually the same as GHB, or the date rape drug before. But they reformulated it so there's a lot of salt, so that if you put it in someone's drink, they're going to taste the salt. So whether or not it's addictive, I don't think it's truly addictive, but you will feel better. I mean, because it increases your deep stage sleep. And so there is some evidence that it is effective in fibromyalgia. Now there's no approval for it. It's an off-label use to use it. When I was still at Stanford, our faculty were actually primary investigators on the studies for sodium oxybate. So Jed Black is probably the guy who's published the most on the use of sodium oxybate, and they were actually using it in fibromyalgia, and there is benefit. The only problem with sodium oxybate is one, it's extremely expensive, so it's very expensive. And I'm guessing with off-label, you're going to have a really hard time getting coverage for it, insurance-wise. The other is there's certain considerations with sodium oxybate. So like I said, it's the same thing as a date rape drug. So when you take it, you're out. You're out for 4 hours. And then you take a second dose at the middle of the night, so you have another 4 hours. But then you have to make sure that you can accommodate that there's someone there to make sure you're safe in the middle of the night. You don't want to take sodium oxybate and there's a fire and you can't get out of your room. But at the same time, you don't want everybody to know that you're taking sodium oxybate because you don't want to have a predator and that comes in and breaks down your door because they know that you're going to be out for 4 hours. So there's a lot of trickiness with sodium oxybate, but basically it's called a GABA-A drug. So it affects a receptor in your brain that allows you to have deep stage sleep so you don't have fragmentation. And part of what we see in fibromyalgia is fragmentation. And so you can sort of see it as addressing fibromyalgia from that standpoint. They're extremely regulated, so it's on a special license and it's centrally distributed. There are central pharmacies. And so it's a little tricky. It's actually very tricky to get. But at the end of the day, I'd probably try everything else first. And if you're really treatment resistant, then you can probably talk to your doctor about sodium oxybate. But like I said, it's a very, very limited license. So you'll have to have a doctor that has the limited license for sodium oxybate. Well, it's not limited by the government. It's limited by the drug company.